Hi, so why don't we get started? Thanks everybody for coming. I'm very pleased to introduce our speaker today, Andrew Huhn, Ph.D., who's currently a Postdoctoral Fellow at Johns Hopkins University School of Medicine. Dr. Huhn received his bachelor degree, a Bachelor of Science degree in psychology from Michigan State University, his Ph.D. in neuroscience from Pennsylvania State University College of Medicine. He worked as a graduate research assistant at Penn State College of Medicine at the Departments of Psychiatry, Radiology, and Neural and Behavioral Sciences. He joined the Behavioral Pharmacology Research Unit in the Department of Psychiatry at Johns Hopkins School of Medicine in 2016 and is currently working in that capacity. He is the first author of 6 published or in-press manuscripts, with several more currently under review or in preparation. He's positioned himself as a translational scientist with special focus on advancing the use of precision medicine approaches for the treatment of opioid use disorder and has experience in both the human laboratory and clinical settings. Please help me welcome Dr. Huhn.
Great. Well, thank you so much for having me. It's really a pleasure to be here. This is my first time to Roanoke Valley area, and it's just a beautiful setting for this research institute. And certainly there's a lot going on here with the new facilities being built. I'm going to be talking today about my topic that I've become very passionate about, and that's applying a precision medical approach to opioid use disorder. So the opioid use epidemic, the opioid overdose epidemic, is a public health crisis. And unfortunately, it's something that started with good intentions, a call to do a better job treating pain, to treat pain like the 5th vital sign. And I agree. In addition to doing research on opioid use disorder, I also do research on pain. And we do need to do a better job treating pain, but we also need to consider the abuse liability of the medications that we're prescribing. And unfortunately what happened is that in the late 90s, there began just a general overprescribing of prescription opioids. But to make things worse, there were these kind of pain clinics that were popping up that had extremely negligent prescribing habits. And so a lot of people got into opioid use disorder through these pain clinics, and a lot of those prescriptions got diverted onto the street and were used illicitly. Between the year 2000 and 2010, the overdose death rate from prescription opioids quadrupled. And it started to get attention from regulatory agencies, from the DEA, which started to crack down on some of these quote-unquote pill mills. At the same time, however, we saw an influx of high-quality, low-cost heroin hit the street. And so what happened was a lot of people were getting cut off their prescriptions, switched over to heroin use. And many more people, just kind of supply-demand economics, it's widely available and it's cheap. Many more people tried heroin for the first time, and we saw a spike in overdose death due to heroin. And now the situation is getting really bad, but it's going to get worse, because in 2013 we saw a spike in heroin that is laced with fentanyl or fentanyl analogs like carfentanil. And I trust an anesthesiologist to do the proper dosing of fentanyl, but it's a very potent opioid analgesic, and so I don't trust the guy in his basement cutting heroin with fentanyl. And you can create kind of what you might call a hot batch where everybody who tries it is going to end up overdosing, and that's what we see happening in clusters around the country. So really this is an epidemic, and it's an American tragedy, because behind these numbers are real people who are suffering. And there are still several states who continue to see a rise in overdose death, and Virginia is one of those states. In fact, between the years 2015 and 2016, there was a 35% increase in overdose death in this state, mostly driven by counties in Northern Virginia outside of D.C., this kind of D.C. suburban sprawl out into the rural areas, and also in counties down the west side of the state, all rural counties along the Appalachian Mountains through the Roanoke Valley. We're in one of them right now. So this is not only a problem nationally, but it's also a problem locally for folks here. So my research really can fall under 3 broad categories. One is preventing the onset of opioid use disorder and increasing access to treatment for folks that have opioid use disorder. Optimizing treatments through medication strategy and testing that in medication trials, and then also maximizing treatment outcomes. So using biological and subjective measurements to predict treatment outcome in the hopes that we can allocate our scarce resources to those individuals who need it most. And this is kind of the mantra of addiction medicine. Addiction is a disease marked by chronic relapse. There are many nuances in treating addiction or treating opioid use disorder, but it is comparable to other chronic disease states. And one of the most often made comparisons is with diabetes. Now, this isn't a perfect analogy, and I think sometimes it gets a bit overused, but nonetheless, there are some definite comparables. So both are driven by behavior, unless you have type 1 diabetes, which is only about 10% of diabetics. Most of type 2 is driven by behavior, right? It's driven by overeating. There's a genetic component to both, but for addiction, there is no addiction gene. There's maybe a set of genes that tip the scales in or out of your favor based on your behavior and based on your environment. Both are chronic in nature. That means once you have them, you'll have them for life. However, patients in remission lead normal and productive lives, and you wouldn't know the difference between a patient in remission with opioid use disorder and a patient in remission with diabetes. The biology of addiction stems primarily from the central nervous system. The biology of diabetes stems primarily from the endocrine system, but both disease states affect multiple systems of the body. Unlike other areas of medicine and unlike other chronic disease states, addiction medicine developed mostly apart from mainstream medicine. And they're really, overall, we are not well integrated into healthcare systems. It's a problem. The system for treating addiction is fractured. And we have many lessons that we could learn from other disease states. I mean, you can look at examples far outside of our disease state, like oncology and cardiology. There are places like MD Anderson, Mayo Clinic, Cleveland Clinic, where they have built research right into treatment. They've built the research into the healthcare system so that they're constantly collecting data. Those scientists can analyze the data, they talk to physicians, and they change the way they treat patients. It's a very patient-centered approach to care, and really this is what we need in psychiatry in general, and especially in opioid use disorder treatment, because we've kind of hit a ceiling at how well we're gonna treat the disease as it stands. But again, unlike other chronic conditions, like let's say I think I might have diabetes. Well, there's really no question where I would go for care, right? I would go to my primary care physician, and that would kind of be the gatekeeper into the rest of the healthcare system. Not always the case for people with opioid use disorder. There are several treatment options that they could try. They might not feel comfortable talking to their primary care physician, and their primary care physician might not feel comfortable talking to them. And that's one of the first problems is where is this first point of contact where people are going to enter treatment, and how can we shepherd people into treatments that we know work the best for them. So there are several medication-assisted treatments that have been shown very effective in this population. First one is buprenorphine. This is a partial opioid agonist at the mu opioid receptor. It will compete with other illicit opioids and block the euphoric effects to some degree, and generally just suppresses withdrawal symptoms. There's methadone, which is a full opioid agonist at the mu opioid site. Both of these are considered opioid maintenance therapies. So the individual does need to take them on a daily basis. But there are alternative medication-assisted treatments like extended-release naltrexone, known by the trade name Vivitrol. This is a once-monthly depot injection, and it blocks the euphoric effects of opioids. It's an opioid antagonist, and it also reduces craving, generally reduces craving. There's a new formulation of buprenorphine that just came out that's also a once-monthly injection that will play a role down the road. But you don't have to go to a medication-assisted treatment right off the bat, right? You can make your own decision. You can choose your own adventure here. So you could go to a 12-step group first, right? Narcotics Anonymous. I've seen a lot of that. I see that in the movies all the time, right? People go and sit around and drink coffee and talk about their problems. And it does work well for many people. Residential treatment facilities that are well equipped to treat the acute nature of the disease. So generally when people are coming into recovery, they are in a state of crisis, right? People aren't out there shooting heroin and they say one day, well, geez, everything's going great. I think I might try to kick my heroin habit now. You know, it's, people are in a bad situation. And so these facilities play a major role in getting people kind of stabilized, but it's short term, and so there needs to be long-term care. This is a chronic disease state. Counseling could be a treatment on its own. Any of these treatments could be layered with another treatment. Well, maybe not all the medication-assisted treatments, but counseling can certainly be layered with other treatments, and you could start with a very high level of treatment and taper people off as they get better. But there's no objective indicator of kind of how to do that and when it's appropriate to transition. In addition, people with opioid use disorder have some barriers to treatment entry, and the first one comes from the person. You know, are they willing to engage in the treatment community? Do they have access to treatment? What treatments are locally available to them? Socioeconomic status, can they even afford the treatment options that are available to them? So these things play a role in kind of where people will enter treatment. And there's been some interesting research done on treatment preference for people with opioid use disorder, but it's always done at the point of contact. So people are surveyed when they come into treatment and asked what their treatment preference is. But they've already shown up, right? So we wanted to take one step back from that and survey people who are actively misusing prescription opioids. And in the different studies I'm going to talk about, we'll kind of bounce between a prescription opioid population and a heroin-using population. I'll make those transitions clear. But this is people misusing prescription opioids. To reach this population, we used Amazon Mechanical Turk, which is an online survey platform. People can sign up for Mechanical Turk and take surveys for money. It's often done in marketing, but more and more public health academics are reaching out to the population through these means, and it's a nice way to kind of to grab a large amount of data. So the goals of the study were to understand the perceptions of various treatment options by people who are out there actively using. So they're not treatment seeking yet, but we want to know kind of what they think about these different treatment options and where they might seek treatment first. And also understand the role that their socioeconomic status might play in shaping that treatment preference. And so we sampled participants, there's 357. They were closely matched to the National Survey on Drug Use and Health, or the NSDA. The NSDA is kind of the gold standard population health survey for these purposes. And so they had an average age of 32.6, about 51% male. We did oversample Caucasians by about 10%. However, we used a rather elaborate eligibility screen, such that only 4.5% of participants who tried to get into the survey were actually able to get in. And in 2016, 4.5% of U.S. adults misused a prescription opioid. So we felt pretty good that about the way that we sampled this population. One thing to note right off the bat is that these individuals were uninsured at a rate double the national average. However, the people in this survey weren't unemployed at a rate double the national average, so there's insurance continues to be a problem. We asked them to rate different treatment options on a 0 to 100-point visual analog scale based on their knowledge of the treatment, and then kind of given that they had marginal knowledge of a treatment option, how effective they thought that treatment was in treating opioid use disorder. And then we used those kind of perceived effectiveness scores to run a principal component analysis to cluster some of these groups of variables together for the purpose of predictive modeling. And this is how it shook out. So the first factor ended up encompassing kind of counseling and detox type treatments. So people tended to view these treatments together. Residential, one-on-one counseling, different types of counseling, CBT, inpatient and outpatient detox. The second factor that emerged was all the medication-assisted treatments. And then also there were some oddballs like physician visits. Would you just go to see your physician? Sober living environments like a halfway house, 12-step groups, and we asked people to just check which of these treatments they'd be willing to use, and they could check multiple treatments for this portion of the survey. And so I just want to point out that the most preferred treatments from this group of individuals are the same treatments that you might see portrayed in the media in a very favorable way, right? Like if you have an addiction, you go to rehab and you get well. 12-step groups you often see, on TV and the movies and such. And these can be good treatments too. Physician visits were also there, but the medication-assisted treatments had lower preference scores, which was disappointing because we know that those treatments are more effective at keeping people in recovery. And it largely followed what was, in addition to kind of what you might see in the media, it followed what's locally available. So people actually knew about counseling services, physicians, 12-step groups in their local community. They didn't know as much about whether or not there were medication-assisted treatments available. So we started to think about all the things that might influence where a person would seek treatment first. So not just like, would you ever use one of these treatments, but where would you go first if you decided you wanted to enter treatment today? And we asked them that hypothetical question, and we added these variables to a logistic regression model, and then we kicked out all the variables that weren't significant and ran it a second time. And so this is what we found, that essentially people that were willing to utilize a counseling detox for initial treatment tended to be male, tended not to have personal insurance, and knew of local availability of these treatment options. People who preferred a medication-assisted treatment tended to have a more severe opioid use disorder, so we had them do the DSM-5 checklist like a proxy of self-reported opioid use disorder. It's not a clinical diagnosis, but it's the best you can do in an online survey. Whether they had insurance that they knew covered these medication-assisted treatments, whether they were locally available, and whether they had used heroin in the last month. So perhaps a more severe subset of these participants. And then seeing a physician was simply associated with having insurance and knowing that there was a physician locally available. So what this kind of, I think, drives home is that insurance coverage and treatment availability play a major role in where somebody will seek treatment first and whether or not they will engage with the medical community for treatment. And really understanding where these individuals will enter treatment for first can inform our public policy efforts as we try to kind of shepherd people into treatment options that work and that treat the disease as a chronic disease. So even when somebody gets into treatment, however, there are several relapse risk factors. The first and most powerful probably for somebody with opioid use disorder is acute withdrawal symptoms. So many people can't make it through the withdrawal. But even if you kind of get through withdrawal, you get the monkey off your back, the circus is still in town, right? And so there are these protracted withdrawal symptoms that can last for weeks to months. Of course, there are comorbidities like other mental health conditions, external factors like socioeconomic status, access to treatment.
Question?
Yes.
On the last slide, I'm just curious, on the comorbidities, were you able to tease apart the data? Is there any suggestion that the onset of the comorbidities with respect to the onset of the opioid addiction, whether that's an issue?
Like whether people with other mental health conditions are more susceptible to?
Yeah, whether they started, some other problem that came up about the same time or not, or something with a long-standing condition. And then
Yeah, not in this particular survey, but some of that work has been done. There's definitely for opioid use disorder, depression, depressive symptoms, and of course PTSD is also another risk factor. In some of the data I'm going to show later, depressive symptoms are a predictor of relapse risk also in this population.
So I guess that's a effective question. That's a good one. whether the person soon after the manifestation of the depression turned to opioids, or whether it was a long period of time between that, whether that is likely to be this factor.
Yeah, I don't have good data on that, but I think it's a really good question. Okay. It's something we could look at in kind of a population study. So supervised withdrawal is maybe the most widely used clinical procedure to treat opioid use disorder, but research on this topic has stalled. It's really fallen out of favor in the research world because we have opioid maintenance therapies that tend to work better. However, I would argue still that this is important for several reasons. A, it is the most widely used treatment, and so if people are still trying to use it, we should make it as good as we can. Also, we can't expect 100% of people with opioid use disorder to go on maintenance therapy for the rest of their lives, so they're going to have to cross this bridge eventually. And if they want to use naltrexone or extended release naltrexone, they will have to go through supervised withdrawal first. So there's some reasons that this research is still important. And I'm going to show data from a parent study and then secondary analyses that I did. This is the parent study. It's a supervised withdrawal study that looks at two medications that are commonly prescribed in this situation. One is clonidine, which is an adrenergic agonist, and another is buprenorphine. A buprenorphine taper is often used over a 7-day period. However, once you go off taper, there's often a rebound of withdrawal that lasts a couple of days and is a problem. So we wanted to look at this with extended release tramadol, which is also has some opioid agonism properties, but is lower abuse liability and easier to prescribe than buprenorphine, to see if that might be a superior medication for tapering somebody. This is what the population looked like. This is not a prescription opioid use population. This is an urban injection drug using heroin population. And they tend to be older. They've used heroin for many years. They were randomized based on many of these factors: age, gender, etc. They also so this is a double-blind, double-dummy research design. So all the participants came in for 7 to 10 days before they went through a taper, and we maintained them on morphine while they're there. We do this because there's no other way to really control for the different amounts of heroin that people are using, the different purities that it might be. So it's at least a way to get people kind of on the same footing. And then give them a naloxone challenge. Naloxone is an opioid antagonist. It's the same thing you would give somebody who's in an overdose. If you give it in a very small amount, it will precipitate withdrawal symptoms for like 30 minutes, which is uncomfortable for 30 minutes, but then it goes away. And so we would look at the severity of their withdrawal to the naloxone challenge and use that as another factor to randomize them so that the groups were pretty equal. They would go through a 7-day blinded taper, double blind. They could either be on clonidine, tramadol, extended release, or buprenorphine. And then after 7 days, everybody's switched to placebo, but they don't know the switch has happened. So this is just what the subjective opioid withdrawal looks like. This is how the participants rate their withdrawal, and this is the study day. So you can see during the taper at the beginning, there's very high withdrawal. For the clonidine group, they had a higher withdrawal scores than buprenorphine or tramadol. And then after everybody gets switched to placebo, we see this rebound effect with buprenorphine, such that their kind of withdrawal symptoms return for a couple of days. That doesn't happen in the tramadol group. So again, I think the main takeaway from this particular trial was that tramadol, while it's not different than buprenorphine in withdrawal suppression during the taper, that post-taper it showed some advantage, and that it's a drug that's generic, so it's cheap and it's easier to prescribe, and it might be a better medication choice in this particular population. And so we wanted to look at something that we've noticed in these individuals as we do withdrawal trials, withdrawing people from opioids, is that you see pretty wild variability on the type of withdrawal that people go through. This is just an observation, but I mean, you see some people are really in bad shape, and it looks something like a mix between the flu and panic attack and insomnia for several days, and it's really nasty stuff. Other people have some withdrawal symptoms, but it's not that severe, and we don't really know why that happens. So we wanted to look at the results from this naloxone challenge and do a cluster analysis, a K-cluster, to look for an opioid withdrawal phenotype. So is there a phenotype of people that are just experiencing higher opioid withdrawal, and that could be a primary biological driver to keeping them in active opioid use. So the cluster did reveal two groups, one that had high opioid withdrawal and one that had what we'll call relatively low opioid withdrawal. This was consistent whether the patient self-reported the withdrawal or whether a clinician took a measurement of the withdrawal independent of the patient. The patients that had high withdrawal tended to drop out of treatment at a higher rate, so this is treatment retention, especially if they were in the clonidine group, so if they didn't have any opioid taper, they had very high dropout rate. And then this is actually what I think was the most interesting part of this analysis. So this is the low withdrawal cluster, and as you can see, it doesn't matter what medication you put them on; they're going to experience some withdrawal regardless, but not a very high level. This is the patient group with the high withdrawal phenotype, and they are really the people who are driving the results of the parent study, such that the clonidine group, they have much higher withdrawal during the taper period, and the people in the buprenorphine group are the ones that are pushing this whole kind of buprenorphine rebound effect. So you don't see it in everybody, you're only seeing it in some people. And so it's a way to start kind of stratifying this population down and getting more towards a personalized approach for medicine in opioid use disorder. And so, again, we think this is pretty exciting data. We need to collect more data on this topic. There is not a lot of ongoing research on opioid withdrawal right now. And also, I think it also, lends some validity to the naloxone challenge has been used for a long time in an experimental setting, to kind of understand opioid withdrawal. It's almost never used in a clinical setting. However, it could be. It's not a very difficult procedure, and it could help a clinician to determine, a patient comes in and they want to go through supervised withdrawal to determine whether or not that's actually an appropriate form of treatment for them. And if it's not, then maybe we can shepherd those people into a maintenance therapy for a period of time and then reassess down the road. And that might be a more responsible way to handle it. So even if you get through withdrawal, I said withdrawal is the first and kind of most powerful driver of opioid relapse, but then these protracted withdrawal symptoms can last for a long time, and they include impulsivity, risky decision-making, depressive symptoms like anhedonia. Anhedonia just means the inability to experience pleasure from something that should be naturally rewarding. Also stress reactivity, which can be measured biologically via the hypothalamic pituitary axis, and you can actually measure cortisol in the saliva, which is a nice, easy biological measurement to take. Also, ongoing sleep disturbance is a major complaint among these among patients who are in this kind of protracted withdrawal, and again, another topic that's really understudied in this population. So this brings me to the next study we did at the Caron Treatment Center. Caron is a residential treatment facility. It's in Wernersville, Pennsylvania. It's 12-step based recovery, and this population that we were working with is a population with prescription opioid use disorder. So prescription opioids are the primary drug of choice. Patients that come to Caron can either stay for primary care. All patients stay for primary care, so it's at least a 28-day stay. Some of those patients can stay for an additional 90 days if they choose to, and so it actually gives a nice opportunity for us as researchers to be able to follow a patient group through withdrawal and do follow-up data collection in a kind of captivated audience over a 4-month period. And so that was the goal of one of the goals of the study was to determine the course of re-regulation. Do the executive function re-regulate over this period of time? Does the HPA axis re-regulate over this period of time? And also, and what I think is more, the most important part of it is predicting treatment outcomes. So are there objective and subjective measurements that we can take from patients while they're in treatment that inform us of their relapse risk when they leave? And so this is what the study was supposed to look like. The patients, we had planned on taking 50 patients that would stay for 4 months. And this is just an example of, you have a good idea and then it hits the real world and it doesn't always work the way you want it to. So we had a really, really hard time identifying patients to recruit right off the bat that were actually going to stay for 4 months, such that it was not going to be feasible in the amount of time that we were there. So what we did, we bumped up the patients that we were going to take in just the first month, and we bumped that up to, we got 77 participants signed up. And then 22 of those participants went into the second month, and 11 of those participants went all the way to 4 months. So it was a way at least to get a larger group of patients in 1 month, and I will say that that tends to be a more clinically relevant group anyways, because in the real world people aren't staying in, or I shouldn't say in the real world, but in most cases people can't afford nor do they have time to stay in residential treatment for 4 straight months. It's more reasonable and it's kind of the standard of care anyways to do 1 month. And then we followed participants for 90 days when they went back out into the community. We collected hair samples, or we would confirm with, Karen does some urinalysis testing, as a biological measurement of whether they had returned to opioid use back out in the community or whether they had returned to any other drug use as well. But return to opioid use was the primary study outcome. And so part of my main interest in this study had to do with stress and whether these stress systems re-regulate over time in these patients. And so on the left I show diurnal cortisol throughout the day in their first month of treatment. So this is about 21 days into treatment. They've gone through a supervised withdrawal, but they're still, mostly in that period of protracted withdrawal. And we did have 40 age and gender matched controls. So as you can see, the controls have lower cortisol at each time point throughout the day. There's practically no variability in the controls time point by time point, and that's because the HPA axis is a tightly regulated system. It is reactive to stressors in your environment, but hour to hour, your cortisol follows this general pattern. So it's highest in the morning right when you wake up, and it kind of falls throughout the day, and it's lowest right before you go to bed at night, and then it builds in your sleep and is highest again when you wake up in the morning. So then this is over a 3-month period, or I'm sorry, a 4-month period. You can see that the cortisol curve shifts down, such that by what we would call data burst 3, but which is actually the 4th month, that it's pretty much even with their control participants. And as a sensitivity analysis, we had like 7 patients who gave us really good data all the way through. And so we pulled those 7 patients out and just looked at it data burst to data burst, because we're using a mixed model here that gets progressively smaller, right? This is like 77 patients and this is like 11. So we pulled out those people that gave really good data, and just as a comparison to show that the subgroup acted the same as the larger groups. But what the study really revolved around, what was kind of the most important aspect of it, was the use of functional near-infrared spectroscopy, or FNIR. So this device can be used to collect recordings from the prefrontal cortex in real time, and it does so in a way that's kind of analogous to fMRI, in that you're looking at changes in hemodynamic flow. However, and that's a secondary measure of neural activity. However, there are some pros and cons to using this device. I think certainly fMRI has an anatomical scan, and it's going to have better spatial resolution. You know kind of exactly what you're looking at. Much better for exploratory research. But most addiction treatment centers and most outpatient providers exist apart from fMRI facilities, and getting an insurance company to pay for that kind of thing for every person with opioid use disorder is probably not feasible. So this is a technology that could be used in any kind of outpatient clinic. It's orders of magnitude less expensive. And it's relatively easy to use. And if you know your target's in the prefrontal cortex, then this might be a good way to take that measurement. This is kind of how it works. You would have a sensor at one point and a detector at another point. The sensor is, this is source and detector. The source is really just like an LED flashlight head. Just like when you shine a flashlight under your hand, like when you're around the campfire and it shows up red on the other side, there's some near infrared light getting through the tissue in your hand and through your bone, and it comes out the other side. And the same thing happens here. A very small amount of light gets through the skull and into the brain, and a very small amount gets scattered back out, and that's what the detector picks up. It gets scattered in this kind of predictable banana-shaped pattern. And that's really scary. Should take that out of the slideshow. So the main task that I was interested in using was this balloon analog risk task, which is a risky decision-making task. And so kind of how it works is the participant is asked to blow up a balloon for money. As the balloon gets bigger and bigger, it becomes worth more and more money. But at the same time, there's an increased probability that the balloon will pop with every pump. So the risk is tied to the reward. It doesn't pop on the same number every time. It's just a probability thing. But if it doesn't pop and you stop pumping the balloon and cash it out, you get this positive feedback. You win, and you get some virtual money in your virtual piggy bank. If it does pop, however, you get this negative feedback. You lose, and you lose the money from that balloon. So again, the risk is tied to the reward. And so we monitored the prefrontal cortex while the participants were doing this task. And what's interesting is that the behavioral portion of the task, so there's behavioral measures here like how many times you pop the balloon and how much money you make overall on the task. And there was difference between patients and controls with that stuff. The patients just tended to do worse on the task, as you would maybe expect, higher impulsivity. That stuff did not predict relapse in this patient population. What was different was the way that their brain reacted to the actual task. And so when we split patients based on those that we know relapsed when they went back out into the community, and those patients that we know remained abstinent when they went back out into the community, we see that patients that relapse saw a decreased signal in response to a win in the ventromedial prefrontal cortex, an increased response in reaction to a loss, and increased neural activity like during the decision-making process. And so this ventromedial prefrontal cortex has strong connections with the orbital frontal cortex and is generally involved in kind of value calculation. So what we think is happening is that the patients are kind of working harder during the task, but having a decreased reward response and increase to the negative feedback, those that are going back out and relapsing. Yes?
For decision reward, is that decisions made are predicated on subsequent learning?
Yep, so it's decisions where where the balloon didn't pop, so they inhibited themselves.
Do you have like decision, how does decision loss look?
It did not differ between these two. Yep. So we put these brain the data from this scan into a logistic regression model, and what I'll note for this particular study, which is almost a little unusual, is the low relapse rate to opioids in these folks. So they relapsed at only a rate of 35%, excuse me, over a 3-month period. They weren't on any kind of medication-assisted treatment, and if you've done any work in this field, you know that that's unusual. So this wasn't a study that was designed prospectively to look at how well a job they do at treatment at the Caron Foundation, but our observation was that these patients were able to maintain their sobriety, at least in the short term. But in a logistic regression model, we're correctly classifying 91.8% of the patients using this device, with sensitivity and specificity both over 90%. So that's actually pretty good when you consider that you're taking a biological measurement at one point and predicting future behavior into 3 months. The model was significant if we stratified the group, so people leaving the Cairn Foundation would either go to a halfway house. Most of them were recommended to go to a halfway house. Many would self-select not to do that. They didn't want to. They would go straight home to outpatient treatment. Those people relapsed at a higher rate, as you would expect, and our predictive model was still significant for those people. It wasn't significant for the people who went to the halfway house, and there's a couple of explanations. One is that they relapse at a lower rate, and that can throw off the predictive model. If it's closer to 50-50, it's a little bit easier. But also, it's entirely possible that some of the people that should have relapsed based on our biological measurement didn't, because they went through this extra level of treatment. And again, we weren't prospectively designed to look at those differences, but I do think it's interesting.
Were you able to predict who would go to the halfway house if you used that, like, decision of where to go after treatment?
Yeah. I don't think so. That's a good one. I'll have to look at that again. Yeah, that's a good one. Yes.
How do you know where you're recording from?
Because
Independent measures what it's looking at, right? Know where the guidelines are, or know where the variation across people to sit on the head.
yeah, you just put the headband on, and then you adjust for head size.
You have a signal. It does the prediction, but you have a very hard time assigning it to the LPS. Your brain's different, right?
Correct. Yeah.
I think you need an independent way to decide what what's called field division method.
Yeah, it's not. It's definitely not as anatomically accurate as an fMRI.
What's the field to do with
You mean how deep can it go?
from how wide an umbrella can go up?
Yep.
How sensitive it is to proton quantum mechanisms that wander into your head, wander through your skull, hit your brain, slow it down, but has a noise from it.
Right. So.
It looked like it was the third thing that I found. And showed a video of the banana-shaped signal reduction effect. So that's not really what light is. Light would go all directions. It's not.
Yeah, of course it does get scattered in all directions. If you have a detector in one place, though, then you kind of know how much light will get scattered into that one single direction.
The spherical source at the skull.
Right.
Also scattering term and numbers provided for also so that you're right on the place so it come out like that. That's the centimeters, right? I mean, that'd be a good chunk of tissue.
Yeah.
Can you do it with EEG? Or
You-
can you do that? Can you do the same thing? Did you also do EEG?
We did not do this project for EEG.
That would work.
I've often considered that. Rita Goldstein at Mount Sinai has done a lot of that work. Yep, there are pluses and minuses to that. I think the real advantage of this particular technology is the ease of use, and that motion artifact doesn't play as big a role because the sensors are attached.
And you took one measurement per person, per subject.
Right.
I kind of got lost in this slide. I took one, it was a 90-day window, right? All of the people up.
Correct.
How many of these measurements did you do?
Just for this particular part of the study, just one.
One
Right.
In the 90 days.
This is while they're still in treatment, and then we followed them for 90 days after they left treatment. Any other questions?
No, it's like pretty good ROC on it. I'm just wondering if there's something generic about I think it's great. Yeah. I think it's almost impossible to go into FDL here. I mean, I'm thinking that's spread of that to something like centimeters. Is that right?
Well,
2 or 3 gyrads.
yeah, I mean, so these represent the actual these are what we would call the optodes. These represent the the numbers represent the size of the area where the detectors are.
You don't really know how much is the size, right? You don't have any, I don't see how you make that conclusion. You have a sensor on top of the brain,
Mm-hmm.
skull. You got nothing checking what's actually happening in the tail, right? That's not how far it's
You're asking me an engineering question that's a little beyond my knowledge about the technology. My understanding is that it goes just, that we're looking at just the outer cortex.
I'm reading enough to count and saying, in the absence of something that was sitting inside the dark for watching that, that's best a crude income, so this is spatial spread issues.
Yep, they have done validation research with this technology where they used the same task in an fMRI and showed that the signals are very similar.
That's separate from signal spread, that's the origin.
Right.
This is a light on my head, and like Bob said, my head probably scattered light mine being much bigger.
Right. Yeah.
Okay, I'm just saying, that's a pretty potent claim without an independent measure.
Okay. Yep, I can. I'll definitely ask my collaborators about it. Yeah. Yeah. Yeah, I think so too. So again, this will just show a Cox regression model where the green line in the middle is the mean for the entire patient population, and then as the signal gets one standard deviation away or two standard deviations away from the mean, that participants are relapsing at a faster rate and at a higher rate. And then the RLC curve, this is just with a leave one out analysis. So essentially you take everybody in the population, you pull one person out, and you use the rest of the group to predict that one person. You put them back in, you do it for everybody as a way to kind of see how reliable your data is. So just in summary, the neural activity in prefrontal cortex during a risky decision-making test was associated with relapse risk in this patient sample. And the patients in general who self-selected into sober living environments relapsed at a lower rate. Suggesting, you know, although that's an observational, the study wasn't prospectively designed to look at that, but that maybe the step-down level of care gives them a better chance at recovery. And again, it's just kind of a way that we can take a biological measurement at one point in treatment and start to stratify the group into people who are at a very high risk for relapse versus those who might have a better chance at recovery, and that we have a resource-scarce environment in addiction treatment right now. And so allocating those resources in a way that's smart is a way to kind of maximize the system to people who need it the most. So again, we did this same study in or not the exact same study, but something very similar. I did the first one in Penn State, and then I took this with me to Johns Hopkins, and I did it in a methadone clinic. Different population, for sure. It's more like injection drug using population. Looking at different types of treatment outcomes, I'm going to focus on return to opioid use. And the sample is a little different too, because we had to collect the sample very quickly because I didn't have the device for very long. So we collected 29 patients in just under 2 months and ran them through a single FNIRS session. They did some clinical assessments for depression and asked them about their opioid craving, et cetera. And then they were followed via medical records from the methadone clinic over a 3-month period to determine if they had relapsed, and kind of how, with this population, it's sometimes like how much they had relapsed. So again, we did the balloon analog risk task. We got significant correlation again. The brain areas shift a little bit, and I think one possible explanation is that these folks are on an opioid maintenance therapy, and they're certainly reacting differently than folks would who have just gone through withdrawal. But we did get a significant correlation. We also had them do a cue reactivity task where they're looking at different types of positive cues. Yes?
A question about this and the other engineers. What is the red and blue represent?
Oh, increased signal or decreased signal.
Can you speculate on the previous why digital war was red and then
And now it's going the other way. Yeah, it's a different area of the brain that we're seeing. This is typically for behavioral inhibition. This might be for working memory. It's hard to say without having like a full fMRI study using this same task, because I don't know what's happening beneath the prefrontal cortex. And again, these people are on an opioid maintenance medication, so that could definitely affect their scores. So again, people could see these positive cues. They could also see a drug cue and then take neutral cues and subtract them out of that. What was an even stronger correlation, though, for this particular population was the response to a drug cue. And so that was very strongly correlated with if they had gone back out and used opioids again. And if you added their subjective craving scores and also clinical depression rating, the Hamilton Depression Rating Scale, into the model, into a multivariate linear regression model, that was very highly correlated and created kind of what we think is a robust patient profile that could tell us kind of how best to allocate resources to these people who are in methadone maintenance. So again, kind of coming back to this idea of precision medicine, are there relevant objective markers and subjective markers along the way that we can collect data and start to assess patients and predict who will go back out and relapse and who won't, based on a given treatment. And then if we know that people are at a high risk for relapse, what other resources can we give them to keep them in recovery? And that's really our goal, is to increase the chance that somebody will stay in recovery. I think I have just a couple of minutes here, so I'm going to quickly run through another type of study. This is a pain testing study for people who are maintained on buprenorphine. And one of the issues with this population is that they already are very opioid tolerant, and they're already on an opioid maintenance therapy. And so the question becomes, how do you dose a person like that if they show up to the emergency room in a situation where they need acute pain relief, or in a perioperative situation for that matter? So nobody's done research on this using kind of experimental pain testing, and so we used a battery called quantitative sensory testing, which includes pain testing for a cold pressor task where you put your hand in an ice cold water bath and see how long it takes for you to start to feel pain, and kind of see how long you can handle keeping it in there. You're always in control of your own pain when you do these type of tests. Also a thermal pressure, or a thermal heat test, where we have an output that just keeps going up. It'll only go up so far, but you rate your pain as it goes higher. And typically in these situations, you're prescribing an opioid. The kind of prototypical opioid would be hydromorphone or Dilaudid. That's generally what's given in these situations. And then there's been some thought in the field that you could just give people more of their buprenorphine dose, and that maybe that would be enough to treat pain in an emergency situation. So we had people come in for within subjects placebo-controlled trial, where they came in for 3 consecutive weeks and spent a session with us where they did a cumulative dose design. At each dose, they went through quantitative sensory testing, and then we also asked them about the abuse liability of the drugs. So these are the results from the cold pressor test. So this is these doses actually go up pretty high. This is 4 milligrams of hydromorphone of buprenorphine, another 4, another 8, and another 16. So a cumulative dose of 32 milligrams, which you would never give a normal person. But these folks are quite tolerant, and there were no serious adverse events in this study. They were either on 12 or 16 milligrams maintenance. So at about the third dose, so at about 16 milligrams, you start to see, this would represent their analgesic response. You start to see some analgesia from hydromorphone. And at 32 milligrams, you see analgesia either from hydromorphone or buprenorphine, but definitely much stronger in hydromorphone. And then this is just data from the abuse liability. So, of course, as you would expect, hydromorphone has a higher abuse liability than buprenorphine, and both have a higher abuse liability than placebo.
I'm sorry, can you go back to the slide? What's the difference between tolerance and threshold?
Oh, I'm sorry. The threshold is when they would first report pain from the cold pressor test.
So it's cold, and then you say, okay, it hurts.
Right, and then the tolerance is how long it takes you to pull your hand out of the bath.
Okay, and their instructor said, do your best, and mother's watch.
Yeah, yeah. For purposes of HIPAA, we can't have their mother watch, but in general, they're asked to do their best. And there's a lot of variability in these pain testing procedures, but it largely mimics the preclinical literature also. So higher analgesia, higher abuse liability, but can give kind of strategy to people in these, to physicians in these emergency situations where they need to treat pain, kind of what the dosing should and could look like for people who are maintained on buprenorphine, which is a growing population of people. But there's also higher abuse liability, so kind of the idea that you might take this medication home with you from an emergency room, maybe not a great idea. Maybe you could use adjunct buprenorphine for that. Interestingly, there's no correlation. This study had a low N, but there were no correlations between abuse liability and analgesic response. And I don't have a great explanation for that, other than these two systems are just appear to be uncoupled in these individuals. And so the same people that were having increased analgesic response were not necessarily the same people that had euphoric effects from the drug. So just ongoing research. I'm working on several studies related to pain right now. One is just looking at individual differences to a study drug. These are blinded studies, so I can't reveal what the study drug is. But we use genetics, neuroimaging, and inflammatory factors to kind of look for what might be driving individual differences in response to analgesia and abuse liability. Also combining medications to reduce abuse liability, both in healthy individuals and in people with knee osteoarthritis, so as a chronic pain model. And again, I can't say what the drugs are, but we're using two of them to see if it's, you know, if we can still provide analgesia, but in a way that's less abusable. And so I'd just like to thank the folks at Johns Hopkins, especially my mentors, one of whom left me for the left coast and went out to UCSF, but I'm still in close contact with him, and then the folks at Penn State, you know, especially the people who are on the thesis committee. So I'm very happy to take any questions. I think I left 1.5 minutes.
So if the dose of buprenorphine was higher, it was still higher, right? At some point, hydromorphone wouldn't have any effect. Would that be correct?
Like if there was a full blockade?
Yeah.
That's what the data suggests, right, right, yeah, for abuse liability, right. Yes?
What kind of inflammatory factors?
I believe we're looking at NF-kappa B, some of the like IL-3, IL-6, that kind of family. Yeah. So people respond differently to analgesics, and nobody's looked at why people respond differently to analgesics. But people report very drastic different experiences, and so we don't know if what plays a role in why people do that. It's hard to describe because I'm not allowed to say what the drug is. Yeah. But of course, if it's right, so it's pain testing also, so inflammatory factors play a role in pain. Yes. So they took their last dose the night before, and then they started the study in the morning. So they still should have been protected by the buprenorphine, but it wasn't at its peak effect. Yes.
I was saw in people that were tapering off measure how many times individuals that increase and then do a full withdrawal
Yeah,
Like the people, the individuals that had easier time going through withdrawal, if they had maybe more experience in the past.
We didn't not collect those data. That's a good thought. It would be different. I mean, of course, it would be subject to recall bias. And you're talking about people who've been using heroin for maybe 12 years. So that would be challenging. But you could, maybe ask what they think they feel like when they go through withdrawal versus what they actually present in the clinic. Something like that might be really useful to know.
Great. Well, thank you very much.
Great. Thanks for having me.